Hi everyone. Where curious minds meets meaningful conversations, I welcome you all to the podcast of the Madras Orthodontic Study Group, a platform for ideas, knowledge and inspiration. It is my privilege to welcome Dr. Johnny Liaw from Taiwan for our very first episode, who will be unfolding his expertise on mastering mini screws. Leading this insightful dialogue is Dr. Srirengalakshmi, Professor, Department of Orthodontics at Savitha Dental College and Hospitals, whose clinical acumen and thoughtful perspective promise a truly enriching conversation. Thank you for tuning in and enjoy this insightful session. Over to you, Dr. Ranga.
Thank you, Dr. Rekha Bharadwaj, the convener of the Madras Orthodontic Study Group, for the opportunity. And a very good morning, good noon, and good evening to all the listeners across the globe. We have with us one of the stalwarts in skeletal anchorage, Dr. Johnny Liaw, and through our conversations, we are going to engage you all with clinical tips and tricks and thought provoking insights from the master himself, whose work on mini-screw anchorage and orthodontic biomechanics has influenced clinicians across the world. Through his research, publications, and global teaching, he has helped transform skeletal anchorage from an advanced concept to an everyday clinical reality. So, join me in welcoming this astounding clinician.
Yeah, thank you. Thank you very much to the Madras Orthodontic Study Club for this invitation. It's truly my pleasure to join you today.
Thank you. It's our pleasure too, Dr. Leo. We all know that the orthodontic treatment protocol varies across different population and based on their malocclusion, soft tissues, and their aesthetic standards. You are the global trotter and you've traveled across the Atlantic, the Pacific. So, what's your perspective of the global trends on the mini screws?
If you have attended some international congress, you will see the approach in different region, very different. Like Japan, Korea, Taiwan, Asian country, because of the patient's demand, we have so many protrusive cases, especially bony protrusion. So we emphasize quite a lot for extraction to improve the facial profile, and we need good control of the upper incisor torque very much, and also the active vertical control to improve the chin projection and also the facial profile. So this is very different with the Caucasian patient. But for the Caucasian patient in some other countries like US or England or many, they do not need to extract so much. So they emphasize on molar decission with tests. But with this basic difference, the approach also very different. As you can see, we have many doctors in Asian country using the buccal test. But in Europe, in United States, most of them, they tend to use the plateau mini screws. And some countries are very good or emphasize biomechanics using tests and delicate, very different in various parts of the world. So I think if we can attend the International Congress more, it would be good to open your eyes. You can see, you can learn from every part of the experts all over the world.
Very true. I should say learning is a continuous process and has no boundaries at all. So, when we evaluate a patient, do you routinely use CBCT? How does it help in planning the mechanics better?
If you look at the ceph, it seems the roots are out of the alveolar bone. But when we look at the CBCT, you can see the continuity of the palatal plate. And actually, the line of the palatal plate can be seen still intact without perforation or dehiscence. That means when we move the roots, the palatal plate were remodeled. So I think the amount of dental alveolar movement might be more than we expect. Because if you look at some CBCT I post in some in my cases, I feel that it seems a more dental compensation we can do than what we think because the alveolar bone, I mean the root can be remained in the alveolar plate, I mean the palatal plate, because we have so many protrusion cases, we retract pretty much.
Yeah, you've said in lectures that mini screws are not just an appliance, but it's a treatment philosophy, right? What mindset shift should an orthodontist make before placing their first mini screw?
I would say you need to think about the biomechanics, and also you need to know the biology, the anatomical boundaries of the patients, and also the effects and the side effects. Because and many times, some design is good for one perspective. However, there might be
Mm,
some
mm.
complications or some side effects from the other dimension. That's the basic I want to emphasize.
So now, the next question. When it comes to treatment planning, the borderline cases are tricky, whether to extract or not. So, how do you handle this dilemma? What is your take on it?
Why
Hmm.
not? Try total arch desization in non-extraction borderline cases. So we shift some extraction cases to non-extraction cases, especially for, you see, low angle cases,
Hmm.
which became difficult cases after
Hmm.
we extract because the bowing effect, even more deep bite after we start the retraction. So this is some early cases that make me change my perspective.
Hmm. So, talking about the total arch intrusion, how do you maximize the effects to address the vertical problem?
We mentioned about the total arch intrusion, right?
Yes.
Then some patients with gummy smile and some patient with open bite and vertical maxillary excess. We started to try to use the concept of total arch intrusion to improve to get the most of the advantage of skeletal anchorage to achieve the total arch intrusion, not only in the upper arch, but also in the lower arch, that we can
Hmm.
maximize vertical effect, correct the gummy smile, to close the open
Hmm.
bite, to reduce the
Hmm.
total facial height.
So, let's get deeper in the treatment of gummy smiles. Gummy smiles, we all know, is like multifactorial in etiology. So, how do you manage to get good success rates in all the gummy smile cases?
I noticed that for the gummy smile case, I also feel that with the upper anterior test, we can correct the gummy smile very
Hmm.
successful. In
Hmm.
my statistics, I do a survey in my cases pool around 10 years, overall near 200 patients. The success rate is quite high to achieve the gummy smile correction in adult patients,
Hmm.
around 98.5%. No, 90, yeah, 97.5% success rate. I think Okay, the other fatal case lies in the etiology factor on muscular etiology, like short philtrum or hypermobile upper lip. So, in terms of the dental alveolar problem or some vertical maxillary excess, we can achieve pretty good success rate for the gummy smile correction. And also we can achieve some borderline surgical case to non-surgical with these kind of total arch mechanics.
Okay. So we've had good evidence for treating hyperdivergent cases with mini screws. But what's your take? And we'd like to hear your experience while handling hypodivergent cases with mini screws.
In the past, we believe that the short face, I mean the hypodivergent patients with insufficient maxillary incisor display. Because in the past, when we try to extrude the upper incisors, it does not work very well because in those patients with low mandibular angle, the muscular force are pretty strong. So they tend to reintrude the upper incisors that we extruded. But using the test, I tried to extrude the upper anterior teeth, but I also use the mini screw anchorage to extrude the upper posterior teeth. Think about that. If you can extrude the upper molars, then there would be some interincisal spaces created, preserved by the molar contact in the back, so that it could help the stabilization of the upper anterior extrusion. So by this way, it is possible to treat the patients, the hypodivergent patients with insufficient incisor display.
We've heard from you about the sagittal dimension and the vertical dimension. Now, let's get into the interplay between the two. So, enlighten us more on the rotation of the jaw basis and how do you use it to your advantage?
So after that, I tried total arch digitalization after that. But um, after we can retract more, the bowing effect became much more obvious. So I start to try to use the anterior test, avoid the bowing effect. But somehow I noticed after we do the combined intrusion and retraction force system, we got some total arch intrusion. Total arch intrusion. After we use the upper anterior test so that we formed a combined intrusion and retraction force system on the upper arch that is directional force. You see, for the class 2 correction, directional force. So with this, we got some total arch intrusion and active vertical control with tests. That means after we intrude the total upper arch, we can get some counterclockwise rotation of mandible to improve the chin projection, to further improve the facial profile after that.
Moving over to the transverse dimension. So, MAPI has been very effective and it has helped us to treat the adult patients better. Can you explain a bit more on that?
And transversely, we also experienced the MARPE, mini screw assisted RPE, so that changed my treatment result of adult patients, the transverse discrepancy. Because in the past, we can only use the RPE in patient below 14 years old. But for the adult patient with transverse discrepancy, usually we will bypass this part to correct the transverse discrepancy. But after we can use the MARPI, then we will try the MARPI for the adult patient with transverse discrepancy.
So next, when we plan mini screws, we take care of the anatomy and always aim for good location with good bone quality. But even after taking precautions, we may encounter failure, right? So how do we navigate in such cases?
Okay. I would say it's more about the patient's anatomy because there would be some individual variations. And the anatomy, if the bone quality is good, of course you can be successful. But at many times, if we know the anatomy pretty good, then we can choose a better position to install the mini screw. Of course, I have mentioned I usually use the buckle IZC position initially. It is because it's very convenient for clinician to use. But I know the success rate is the highest when I install the mini screw on the mid plateau area. So yeah, we need to I mean we need to see our cases and analyze where is the most successful position to install the mini screw. In my statistics, actually my IZC test, the success rate is only about 72%, not very high. But most of the cases I can use that. But but I tend to reinsert a mini screw once I come across the failure. I will try some other place with priority. Of course, choose the I will choose the first priority at first, right? But you need to know where is the second and third. Usually, I will not wait. Once I know the first cannot work, I will move to the second. If the second cannot work, I will move to the third in one appointment.
So, okay, and with multiple perforations in the same visit, how do you manage the soft tissue and, of course, the patient?
After the local anesthesia, you do not need to wait until the failure. You know it will be a failure, right? So you just do it once at once. Then we will see if there, okay, if okay. Sometimes the first time I do this, I look at the intraoral situation. It looks like several perforation I have made, right? It looks awful, but I asked the patient in the next appointment, and the patient told me that it's nothing too much, just like ulceration, because there was no bone. They're just soft tissue, just like ulceration. They do not feel too much pain, and it's not very harmful. But at least we have made the situation clear, and I know where I should to move for the next move.
So, right now, when the continuation of the soft tissue, do you always remain within the attached gingiva? What are your alternate options in cases of failure?
I remain them in within the attached gingiva, within the attached gingiva. So because if I put it beyond the attached gingiva, usually there would be some soft tissue complications. So I just keep them remain in the attached gingiva. But initially, I put the first priority between the upper six and seven. The second maybe between the five and six, And the third might be a mid buckle of the upper six between the two roots. But of course, I do not like that very much. But yeah, we can try as long as you do not hit the roots.
Okay, so let's have another situation here where the buccal bone quality is not good. And what would be your biomechanical plan?
But if they do not work very well, then I need to think about where to put the for next. Maybe I will consider to put on the plateau side.
Mm.
And then usually I will put the two mid plateau screw. Then I take an impression and install some old used mini screw as analog. Then I got a stone with two mini screw on the mid plateau so that I can fabricate a plateau appliance accordingly. That is my that is the routine when I come across some cases that I come across the mini screw failure on the buckle side.
That's a good clinical tip. So that's true. We get a higher success rate with palatal mini screws. So how do you go about planning the biomechanics for various tooth movement like protraction, retraction, or rotation?
Okay. Um, since I do some statistics in my cases, I noticed that the highest success rate are lying in the mid plateau screw. Although I try some other plateau means that some other positions of the plateau screw,
Mhm.
uh, I prefer to use the mid plateau area. I use two mid plateau screw at a distance around 7 millimeters. Then
Mhm.
I use the point 036. I
Mhm.
mean the 0.9 millimeter diameter stainless steel wire to fabricate an I call that MTAD, mid plateau test appliance to retract using the basic, I mean the central position. I can extend the wire to the distal for retraction or extend the wire to the anterior for protraction or one side in the front, another side in the back so I can rotate the arch, the upper arch. So this is usually the appliance I will choose after I fill in the buccal side.
Sometimes, as clinicians, we come across severe skeletal cases, and ideally, we would want to treat them with orthodontic surgery. But then, if the patient are not willing for, invasive procedures, how do we handle such cases? Like, what do you tell them? How do you go about it?
For these patients who want to look for, you know, some non-surgical approach for some severe skeletal discrepancy, of course, we do not know what the treatment outcome we can provide. But of course, we will think about the possible way to provide the possible, the most, I mean, the most perfect outcome we can provide. However, I believe this the patient communication would be very important because you cannot guarantee you can achieve the best without OGS in some cases with severe significant skeletal discrepancies. But of course, even even this, the patient still want to try non-surgical approach. We can try our best, but without inform the patient too much about the possible idea in our mind. We just say we will try our best to achieve the best possible solution for you without OGS. But once it was done, is still very exciting to the for the orthodontist, and that's why I also I try some extreme cases, but I think the patient communication is very important. You need to inform the patient that we cannot guarantee a best possible, I mean, a very good result, something like OGS, but we will definitely try our best to achieve the best.
So, next, coming to the digital age, what is your take on social media and orthodontics, and especially mini screws?
Yeah, possibly. When I see some design of the
Mhm.
test appliances on some social media, it it surprised me a bit. be- When I see, you can see, um, have you ever seen maybe six mini screws for a Marpy, or eight, or even 10? I think if it works, you do not need so much uh, skeletal anchorage to open a plateau suture. And also, you need to figure out the best possible biomechanics for
Mm.
your cases. Just try to simplify use of tests to
Mhm.
simplify the
Hmm.
mechanics. And that's my basic thoughts.
All right. I think after the advent of social media, you also learn what to do and you also learn what not to do. And between the biomechanics and the digital design, what would you prefer?
Yeah, I believe both. Both. You need to know about the biomechanics, but you need to do it by a digital way. Only the doctors who can to combine these two can be successful.
Absolutely. I think both are here to stay. And if you can master both, then definitely success is all yours. And after so many years of teaching and practicing, I mean, worldwide, what still gives you the good excitement?
Publishing this kind of case to let all our colleagues to know. Like um, some cases can be treated to this, but it is also possible to treat it to a higher level. But we are not so sure. We just try our best according to our knowledge or experience. So we need to share our experience with all the colleagues so that everyone can get the idea. Somehow, someday, some patients you may want to give it a trial. And I think this is the way that excited me more.
So, finally, to wrap it up, why do you think should we master mini screws? Is it for the control or the freedom?
If you can master the skeletal anchorage, it can give you control. And this control gives you freedom to design a better result.
Wow, you nailed that completely. Thank you very much. Thank you, Dr. Liaw. And I thank you on behalf of the Madras Orthodontic Study Group and the Indian Orthodontic Society for sharing your valuable thoughts and your precious time. So, dear friends of the fraternity, thank you for tuning in. And until the next episode, this is Dr. Srirengalakshmi signing off. Thank you all.